Hello, everyone. Welcome to TCT Connect 2020. I'm joined here by my friends and colleagues, Dr. Farouk Jaffer from Massachusetts General Hospital in Boston and Bill Lombardi at the University of Washington, both of whom need no introduction. Today, we're going to be speaking for Siemens as a sponsored event, focusing on physiology in PCI, imaging in PCI, and robotics in PCI. We think we have some engaged discussion ahead for you, and we're hopeful to really span the entire gamut of physiology and imaging over the next hour. We're going to start off with my presentation, which is going to be looking at the role of angiography-derived physiology in the Cath lab to guide PCI. Well, there's no doubt that physiology has become an integral part of all of PCI. And now there's very strong evidence to suggest that a physiology-guided approach can improve patient outcomes. But there are some problems with physiology, particularly wire-based, which may be overcome by some new technology, which is an angiography-derived FFR. And we're thinking that this may be able to change the physiology paradigm altogether. So the first question we have to ask ourselves is, why fix what isn't broken? We have very good evidence from the original DEFER study, which now has 15-year data, which shows that the higher infarct rates occur in those patients who had PCI performed. And in fact, most MIs were related to the target vessel, suggesting that deferring a PCI may in fact be safer than the cost of the stent itself if the FFR is negative. We grew in this area by the FAME series of trials. The FAME-1 study showed a clear benefit of an FFR-guided PCI approach compared to an angiography-guided PCI approach. And then we went on to show that compared to medical therapy, an FFR-guided approach was safer and actually had better outcomes for patients. And something that we all strive for in interventional cardiology was proven in this large meta-analysis of FFR over a 5-year time period, where we were first time able to see a reduction in hard endpoints, including cardiac death or myocardial infarction, death or myocardial infarction, and I think most importantly, mechanistically, a reduction in spontaneous myocardial infarction, suggesting that the utility of FFR is actually being able to determine safer plaques versus those that are more at risk. But there are a few limitations of FFR which need to be acknowledged. Of course, the administration of adenosine is recognized to cause patient symptoms. And as doctors and physicians, the first thing we would want to do is to make sure that our patients are comfortable. There is an addition of time related to FFR compared to non-hyperemic pressure ratios. And that time may be administered, maybe due to the requirement of getting drugs from pharmacy, procedure setup time, and of course, most importantly, I would say, is that we need to acknowledge that all of these ancillary technologies have a cost implication. And what we can see in this study from the defined flare and sweetheart analysis is, in fact, that if we perform a non-hyperemic pressure ratio and eliminate the need for adenosine, we can reduce cost. So building on this limitation of FFR was the advent of the first non-hyperemic pressure ratio, the instantaneous wave-free ratio. Essentially an assessment of the physiology during a specific wave-free period in diastole. Originally, in the ADVISE-1 study, the thought was that this specific segment of diastole was actually analogous to the paralysis of the microcirculation that occurs in hyperemia. Subsequently, in the ADVISE-2 study, it was realized that that in fact wasn't the case because there's always a basal level of sympathetic tone in the microcirculation. But nonetheless, they were able to determine an area under the curve of 0.90, comparing the instantaneous wave-free ratio resting index compared to adenosine-mediated hyperemic FFR. And two very large, well-conducted, randomized controlled trials were able to show that over a period of 1 year, an FFR-guided approach and IFR-guided approach were non-inferior in the ability to determine MACE in patients with intermediate coronary artery lesions that required physiological assessment. Subsequently, a lot of work has been put into these different non-hyperemic pressure ratios. And in this study, we found that basically the wave-free period wasn't as magic as we originally thought it would be. And in fact, all the diastolic pressure ratios actually turned out to give a very similar result. So in fact, the non-hyperemic pressure ratios started to look somewhat interchangeable. And over the span of a couple of years, now what we found is these non-hyperemic pressure ratios, whether it's simply a PD over PA, which is available on all systems, the resting full cycle ratio from Abbott, which incorporates the minimal PDPA throughout the entire cardiac cycle, or whole cycle diastolic or subcycle diastolics, all basically gave us the same answer and utility in being able to determine physiological significance of intermediate coronary lesion. So here's an example of a patient with an intermediate coronary lesion, and I think really it doesn't matter whether you use FFR, DPR, RFR, IFR, PDPA, or DFR, they all really lead to the same conclusion. But there are always changes in physiology. In this summary slide presented by Dr. Patrick Sarouis, it was mentioned actually quite early on of the possibility of creating an angiography or CT guided FFR. And the thought process behind this was actually that the future is now, and that angiography-based FFR could be performed by basically creating a three-dimensional reconstruction of the coronary artery and performing either computational flow dynamics or resistance models to be able to determine in high resolution the contribution of individual stenoses to physiology. But then again, we have to ask ourselves, why fix what isn't broken? We have very good physiology data showing that outcomes are improved if we use a physiology-guided approach. It doesn't take that much longer to use an imaging guide wire. It doesn't take that much longer to get adenosine. But when we find that we can have something that has a diagnostic accuracy that's greater than 90%, has high inter-observer reproducibility, has a reduction potentially of complications, is faster and has a simplified workflow, and is reduced consumable cost, in that situation, we start to think when there's something safer, faster, and more cost-effective, that perhaps we start looking at new technology. And this is a summary of the available data of angiography-based FFR, which has now become commercialized. Here, what you can see in this study, which started off with a small number of patients, but now is increasing rapidly, you see a tremendous level of diagnostic accuracy. Really, I think putting forth how good this technology is at being able to mimic intracoronary pressure by wire-based physiology. A lot of accuracies well over the 90% range. And in this sort of state-of-the-art angiography-based FFR assessment, what we're able to see is the sensitivity and specificity of these angiography-based FFRs compared to invasive wire-based FFR is over 90% with an area under the curve of 0.95, really showing that these are getting to the point at which they're really interchangeable. So there's lots of different angiography-based FFR products available. There's Metis, Philips Volcano, Pi Medical, RainMed, Pulse. But we're going to be focusing on one of the products that's partnered to Siemens right now, which is the Virtual FR. And this FAST trial series really talks about the use of VFFR in different clinical scenarios, performing not only just a single study, but slowly iterating to show the utility of virtual FFR in real-world practice. But the question is, does it really work, right? So there's lots of these technologies that are available. How do we know it really works? Well, I think that the proof is in the pudding. So here's a patient of mine, 77 years old, with typical angina, whose status post-Pci of the RCA, who I notice also has multivessel disease. And before closing up in the left coronary artery, I really want to know what I need to tell this patient in terms of whether they're going to come back for something or not. And clearly there's a tight lesion in the LAD, but there's a more intermediate lesion in the circumflex. So the question is, which of these lesions is significant? And I think the real question is this circumflex a problem or not? Angiographically, I think if I went over onto the left side, I'd probably end up stenting this, but clearly there's a need for the proximal LED. So this is going to serve as its own experiment. And what I want to show you is that you can very quickly perform VFFR in practice by basically grabbing your angiogram and dropping it directly into this box, selecting your equipment. What we're able to do is identify where the lesion is and basically perform something analogous to QCA, where we mark the lesion and then tone down to make sure that we've accurately identified our vessel. Here I'm just going to sort of sub-select this circumflex, and this highlights the area of interest for us. And what I need to do is to do this in 2 separate dimensions. So 2 images at least 30 degrees apart from each other that are minimally foreshortened. Again, edit my angiogram so it's not including the circumflex. And then highlight using this red ball exactly where the lesion is. Now what the system will do is create a 3D reconstruction or use an algorithmic approach. And by putting in the systolic and diastolic blood pressure, we're basically ready to calculate the VFFR. And what you can see in a matter of minute, in real time, we're able to see the VFFR is 0.72. But is this correct? Well, when we go ahead and perform an invasive physiological assessment on the same lesion, we see that the FFR is 0.73. So really something that's very accurate and was very quick to perform. So something that really helped me build confidence. But what about the circumflex? Does it really work only in tight lesions? I could have said that was angiographically really positive to begin with. And now what I'm going to do is really go ahead and just focus on another lesion. And focus into this intermediate lesion present in the circumflex coronary artery. We're going to go ahead and follow the same steps encompassing the entire lesion, and then just highlight to make sure that we've got an accurate quantitative coronary angiography assessment. We do the same thing in the contralateral view. And again, you'll notice you don't need many views for this, just something that isn't tremendously foreshortened. And again, remember that this is being performed in real time. This is a real-time assessment which I've recorded for you. And quickly perform an adjustment on the angiography. Use our red ball to center the lesion. And then by inputting the invasive systolic and diastolic blood pressure, which is present on the MAC-Lab, we get an instantaneous VFFR. So in this situation, the VFFR is recorded as 0.85. So let's go ahead and look what our invasive assessment was, and the VFFR is 0.86. So I think what I've highlighted is that there is time for iteration. It is time to move to things that may be safer, cheaper, and better in terms of cost flow, that the diagnostic accuracy according to the data, but also with real-life cases such as this, is actually very accurate. So in conclusion, when to fix what isn't broken: if something's easier, faster, safer, more comfortable, cheaper, more versatile, and can do everything else the prior technology could, it may be a time to consider the new paradigm in physiological assessment. So Bill, you heard my pitch. Do you believe it?
Yeah, I do. You know, I was reading through this. I found one of the interesting things in Orbita, despite all the issues around that trial, 4% of the patients who got physiology got a dissection of their coronary. Now, I don't know what that says about the wire or the operators or other things, but, you know, putting a wire down does have risk. And so if we can do this in a safer way, I think that's effective. As you know, I'm actually a huge believer in physiology. My challenge is most of the patients I have, you can't get the physiologic wires down to do an interpretation. And I think that's a little bit of a different animal. But I think that this clearly looks like simpler, easier, and faster. What I hope is that our profession will be willing to adapt, hopefully a little bit more rapidly, and also to have a little bit more trust of what they find. Because even to this day, you will have people either not do physiology because they just want to stent it, or you'll have people do physiology and it will prove that they don't need to be treated, and they still get treated. So I think any way we can help improve that quality would be very important.
So Farouk, let me move on to you. You know, one of the things we all like to talk about is post-PCI physiology. We clearly know the impact. There's plenty of data to support its use, but let's be honest, it's a real pain. You've just laid a bunch of stent, and now you're trying to get this bent up wire, which you bent the first time because it doesn't have good memory, down the coronary. It's hitting everything. Do you think that an angiography-based FFR system might help us in terms of our long-term outcomes by post-PCI physiology assessment?
I think that's a great point. Yes, 100%. I think knowing how to check our work is something that we are now aspiring to more routinely by imaging and then ultimately by physiology. And you're right. Once you take that wire out and you've got to re-zero it, it's sometimes beat up. We just don't get as much post-PCI information as we need. So I think it's great. I think my general thoughts about virtual FFR and intermediate angio-derived FFRs is really the spread around the middle gray zone. So when IFR was first introduced, we had this kind of defer zone where if it was really high, 0.93, you felt pretty good neutral. If it's less than 0.84 or something like that, you say, okay, that's positive. What do you see about our current state of our technology? Do you think we should have a defer window where we say, you know what, you really should check that with invasive IFR or FFR? That's question one. The second one is a big picture. We clearly need to be doing this. We clearly need to be able to look at multi-vessel patients. Not everyone can have 3-vessel FFR, IFR. We need to be able to get that post-bypass. People going to bypass. Should they get that OM grafted? What about that diagonal? I forgot to do that during the Cath. I wish I would have known what the FFR was. Now you have an opportunity to do it post facto and really guide the surgeons or ourselves for what conduits really need to be looked at and fixed.
So, I think that's the real utility in that this can just become a lot faster, right? All the stuff we like to do, we can now do. I mean, how many times have you FFR'd 3 vessels to send a patient to surgery? It's just impractical. We're like, all right, the patient's going for surgery. We'll tell the surgeon where they should stick some grafts on. But if we could guide that by physiology, I think this is the future, and it's not going away. My personal opinion is that over time, probably the wire-based assessments are going to start being sort of more niche for microcirculatory assessments, sort of measurement of coronary flow reserved. And in routine clinical practice, especially when the workflow for this angio-derived FFR becomes a part of the X-ray systems, that's why I'm so excited about this being part of Siemens, is that the whole thing just flows. You do an angiogram, it comes with the FFR. You know what you need to stent from the beginning. You do your PCI, you press on the pedal, you do a post-PCI physiology, you've got the whole gamut. And I think probably the most exciting part is that there's clinical outcome studies. There are major studies going on, the FAVOR 3 trial, the FAVOR EU Japan study. There's lots of people looking at this in terms of clinical outcome. And I think that's probably what's going to help guide us in the future.
So Ziad, I have a comment and a question. So the comment I'd like to make, going back to what Farouk was talking about, the 3-vessel physiology testing, I thought it was interesting in Syntax 2 that a third of the lesions that they were planning to graft as multivessel disease didn't need it, which means a third of the LADs that we send for CABG to get the Holy Grail Lima actually probably didn't need it. And I've done this several times with people with RCA CTOs. We actually show that the LAD wasn't physiologically significant in the first place. So I do think this also will help improve care because it should reduce unnecessary surgeries and hopefully help us do a better job of treating physiologically significant lesions. The question I had for you is, I'm a big believer in getting the physician out of the equation, that we need to let artificial intelligence prove things. And I saw you doing hand drawing and hand corrections. So clearly we need to do some machine learning and AI work to try and get this so that we take the human hand out of the decision tree, because you're drawing and that's going to, little changes with your drawing can affect the outcome. So are there plans to work to make it a much more automated decision tree?
Yeah, so great question. I think what is immediate or imminent is a sort of flag. When you've corrected things more than 25%, that's already built into some of the QCA software, that it gives you a flag and says, hey, you might be doing some overcorrection. And Bill, let's be honest, this is interventional cardiology in 2020. Maybe some people will be a little bit more heavy-handed with the pencil than the others, right? Let's call it what it is. But I completely agree with you. What ultimately I'd like to see, and I think we'd all like to see, is something that's completely automated, where the system finds the lesion, the system finds the contour detection, and goes ahead and gives us the numbers. I think the key to that also is that you need a good angiogram, right? These can't be overlapped. There are a number of caveats to that. If they're very proximal vessels, they can't be foreshortened. But remember, the best part about this, guys, is it's the first generation, right? You remember when the first FFR wire came down, the Doppler wires? We're in a different era. And I think, with the technology moving the way it is, in the next several years, I think we're going to see something really very refined and something that's just part of the workflow. So on that note, Farouk, you're up. We're going to hear about a totally different imaging modality, CT scanning, and how you use it to guide preparation for CTO intervention, and even how you use it during the CTO intervention.
Thank you so much for the opportunity to be part of this really exciting session. Thank you for the introduction, Ziad, and great to follow your really interesting presentation on physiology. And I hope to share where the kind of other major advance in coronary work has been going, which is in imaging. And this is a discussion about CT guidance for really helping understand how to work with CTO PCI chronic total occlusion. My disclosures. And so one of the questions we've been asking for a long time is whether or not we can do better than just X-ray angiography for defining chronic total occlusion CTO anatomy. And why is this? It's because angiography has fundamental limitations. When there's overlaps and angles that are not optimally refined, we can have difficulty resolving ambiguity. The actual course of the vessel is occluded, so sometimes we cannot see within that vessel, of course, and therefore not understand the proper course. And very often with X-ray systems, it's harder to really appreciate calcium, which can be clearly a significant factor for obtaining success in CTO PCI. So if we don't appreciate these factors, we can have longer procedures, more complications. What about the role of CT? Why would we be interested in CT? Well, fundamentally, CT can actually see the vessel wall. It doesn't need contrast, but because there's soft tissue contrast intrinsically from the vessel wall and calcification from atheroma, we can actually see that gap that angiography can't always see. So some of the roles that have been very established for coronary CT, and this is work from Poonam Velikavudi recently in a review paper, is sometimes we get incomplete angiography. Every now and then we can't see a distal CTO target well. It wasn't shot, it wasn't injected, the collateral wasn't done correctly. CT can be very reassuring to know that there's actually something down there that's worth pursuing anatomically. In addition, we now can take our predictions and understanding of how our procedure will go to a higher level. We can see things that angiography sometimes will underappreciate: stent fracture, severe calcium, do a better job with occlusion lengths and looking at vessel areas. And this has turned out to be really validated in CT-based scores. KCCT score, most recently CT Rector score, have really shown that we can actually do just as good, or and even a better job than angiography at predicting guide wire crossing and CTO success. And then finally, real-time CT fusion, actually taking the X-ray information, CT information, and fusing it on top of the X-ray during PCI can actually have some emerging advantages, and we'll share some of that here. So just to go back to what CT can do compared to angiography, it's now well established that incomplete angiography, we don't step on the pedal long enough, don't fill those collaterals. By CT, which is injecting approximately 100 cc's of contrast in steady state, one can get really a much more true definition of the coronary anatomy. We can see whether or not vessel entry is tapered or blunt better. We can see bending and anatomy better. Calcification, much greater appreciation on CT because it's just so much more sensitive. And then the occlusion lengths, which sometimes look long on angiography, if we don't inject multiple sources of collaterals, we might overestimate the length. It can turn out to be significantly shorter on CT, which is, of course, filling the entire heart with contrast during that 100 cc bolus. And this is borne out by AUCs, really showing that CT can outperform Cath for both overall procedural success and for 30-minute guidewire crossing. So how are we going to take this further? So even if we have CT, are we really going to be able to use this to its full capacity? Well, what if we start to actually have enough of a data set of CT and CTO-PCI procedures where we can actually start to compare what did our CT and angiogram combined tell us about how this procedure went? Ultimately, we will build libraries for looking at both CT and the CTO cases to understand what our relative success rates will be. What strategy should we actually try? It might inform us, well, here's your success rate for antegrade wire escalation, antegrade dissection reentry, and retrograde. If we knew that up front, we might seriously change the way that we approach some of these procedures. We'll start to build these libraries. CT will be an important part of understanding success and failure outcomes. And then ultimately, we'll get to hear from Bill at the end of this next presentation about the exciting work in robotics. What if we can actually ultimately just execute our recommended CTO-PCI strategy from robot from start to finish one day? So I'll now spend some time talking about the real potential for real-time CT to guide PCI success in CTO patients. Again, we know from regular CT offline that we can get a lot of information, but we can only really provide limited guidance. We've got to choose some key images to display. But when we do the cases, we're all over the place with our angles. When there's gear inside the coronary artery, there's deformation, so they may not really match our resting CT scan. The ability to take real-time CT information and fuse it on top of the X-ray can allow us to see that gap that angiography can't fill for us. So recently, a few years ago, and Bill was involved with this study, is we looked at 24 patients who underwent CT segmentation, looking at how we could extract that CT information and then fusing it real-time on the X-ray fluoroscopy system using Siemens-based technology. And this allowed us to make several insights into how coronary intervention would go in complex lesions like CTOs. This is just a representation of the centerline extraction that is used for CT, and then how those center lines are then fused. We will typically take 2 angiograms at kind of 40 to 50 degrees separation, and then that puts a kind of central center of reference. That center of reference takes the CT information and it puts it right on top of the X-rays. And so we can do fluoroscopy with these lines overlaid on a separate screen right next to our main fluoroscopy screen. One thing that we learned in a case of antegrade dissection reentry that CT helped resolve when it was real time was a mechanism of failure. We were trying to re-enter here into the mid-right coronary, right at the kind of bifurcation of the PDA and PLV. We had an occluded vein graft. You can see this now from CT. It was outlined ahead of time. When we tried to do re-entry in our initial spot here, we actually failed. And it turned out when we looked back that we were trying to re-enter against a block of calcium. Now, we don't always appreciate that. CT is much greater for that sensitivity. It's very obvious here on the CT fusion. But when we ultimately succeeded, we further found that we were in between 2 blocks of calcium. This was our successful reentry spot. So this might be a way that CT can help us say, well, let's put our balloon in places that are away from highly calcified areas. Can't always see that by X-ray, but with the CT sensitivity right on top of it, we can have some additional guidance. Here's a case of a real-time patient, a real-time case for a patient who had severe angina after early bypass failure, right coronary total occlusion, breakthrough angina despite medical therapy on 3 antianginals. Here's his setup films showing that the right graft was now occluded. He had a blunt, ambiguous mid-right coronary total occlusion. Here you can see in the middle panel. Where does that actual total occlusion starting? Well, many people would look at this and say, this might be a primary retrograde case. It's such an ambiguous situation. And that could be fine, but our retrograde options here were most promising in epicardial collateral, which we know was very high risk, not an ideal first choice. Our vein graft was totally occluded, so no guarantees that instrumenting that would be allow us to make a retrograde successful approach. So we can do other things. We can use real-time IVUS. We can get information. We can use techniques like Open Sesame, maybe to get these things open. But what if we had direct guidance of knowing exactly where that mid-right coronary was? So using the CT overlay here, and this is a static image really defining this, we actually were able to segment the branch and the main vessel from CT and put it right here at this vertex, right where the RV branch hits the main branch. Then, using this in real time, we were able to now attack this area, still being, somewhat cautious because it is, not a perfect match, but a very close match, that we might be able to use a more aggressive approach to start proximal cap entry. When we did that here, and this is a real-time display, we actually put a balloon up in the side branch as a blocking balloon, really positioning that balloon right at this vertex, then move the vertex over so that we could watch in real time. And what we found is that we were able to make progress into something that was tracking the mid-right coronary. When we stopped here and we then moved that overlay, we looked like we had the same kind of 30-degree angle between that. We said, that looks encouraging. Let's see if we can make a knuckle, and we pushed further and were able to do so. And then again, confirmed through the overlay that we were on target for the mid-right. This happened to be a stiff wire. It's not something that we ideally want to do, but because it was so difficult to actually get going in that proximal cap, we pushed forward, we had a small knuckle, then we changed and de-escalated to a polymer jacketed wire, knuckled further all the way down to the distal right, finished the XT dissection, did a successful re-entry and stick and swap, and ultimately had a good result from an antegrade only case. And so this is something that really de-escalated the risk of retrograde work by using real-time antegrade guidance. So in summary, compared to X-ray angiography, pre-procedural CT offers superior assessment of arterial course, tortuosity, and calcium. The ability to use real-time guidance can further help CTO PCI, in particular by resolving proximal cap ambiguity and appropriately appreciating calcium. And this might help with more complicated CTOs like antegrade dissection, reentry-based, and retrograde-based procedures. We need prospective studies to further test to see if we can become faster and safer using CT fusion. And with that, I will conclude, and thank you so much for your attention.
Farouk, that was fantastic. And I think a real highlight of where we can use other technologies other than just the lab-based technologies. And, unfortunately, you guys are a little bit of victims of your own success. The easier CTO cases are now being done more and more by operators that have been taught by you guys. And the reality is that these are becoming more and more complicated, more ambiguous caps, more sort of tortuous or questionable anatomy. And so the role of CT moving forward is going to really be important. So some of the questions I have, though, are practical. So Farouk, now I got to give another 100 cc's of dye. When do I do that? How long before should I bring the patient in? I obviously don't want to do it on the same day. So that's one issue to bring up. And the second is, and I've suffered through this on my own, is who's supposed to interpret these for you? Are you downloading them and running them on software that's available to you? Or are you going to meet your radiologist as part of your planning procedure? What's the Mass General workflow for CT-guided CTO PCI?
Thanks for that question. It's super important, and I did not go granularly through that with the time limitation, but super important for practical use. So for more complicated CTOs, where we know there's proximal cap ambiguity, long segments of occlusion, post-cabbage vessels, it's part of my routine clinical assessment. I will often get CTs to better understand the native anatomy. And I do that really for clinical reasons. There are so many things that I learn about those more complicated blockages, not necessarily routine. And again, I would also couch this by saying, when you have someone like Bill who's done thousands, your need for this is different than someone who's just kind of beginning in their program. Or even for me, I still like at 700 or whatever. I still learn something every time, and I think especially as we see this growth in this area and interest, this may be a tool to help people more safely acquire expertise without as much risk. But the way that it works is once we get the CT, these are officially read studies by MGH Radiology, and all the cardiac CT radiologists now really understand what we're looking for. They'll characterize the CTO. They'll give us effectively a JCTO assessment of the lesion of interest, which is also very helpful ahead of time. Then in order to get the information, we think this is a real-time case, and almost every single person that has a CT, we will extract that CTO. We will take the center lines out, and that used to be done in a more kind of time-consuming process with radiology. Now, my research technologist, clinical research coordinator can do this in about 15, 20 minutes. About 5% of the time, there'll be some ambiguity with the segmentation that we might reach out to our radiology colleague, Brian Goshadra, and say, Brian, can you make sure that we really have this right? I've increasingly become facile at understanding, the way to segment these lesions, looking at the key branches. And the most important part is really segmenting the parts just at the top and the bottom of the CTO segments, looking for branches just north and south of the proximal and distal caps. Once you get that in place, really the rest falls into line. So it does take some dedicated experience, but now our 15 minutes that our coordinator will spend doing it is really very helpful for real-time display.
So Bill, I think there's probably no one in the world with the experience that you have in CTO PCI. I could ask you, do you really need this? When do you use CT? When would you use CT? And honestly, do you think it's necessary?
So I'll listen. All of us are trying to get better, and and the issue is for the number of patients that have CTOs, the number of people who are referred to bypass surgery effectively inappropriately because they don't have an LAD lesion, but they have an RCA CTO that people don't like. We need to be able to make this a safer, more efficient procedure. The two current challenges are calcium and ambiguity. So I think that as we try to expand this, I didn't think I'd be here when I started 15 years ago because I thought people could learn it. I didn't think it was as challenging for people to pick this up. And there's a lot of social, societal, interpersonal psychology issues that go along with that. But I think CT solves ambiguity. I would caution people to be somewhat careful until it really is three-dimensionally sound. It may not solve ambiguity as well as we like, and you need to be facile with all the different solutions in regards to it. So I do not routinely do it because I don't have access to this overlay technology. The places where I will use it are usually in patients who have significant anatomic ambiguity or cases I've failed because of anatomic ambiguity. Now, over the years, because we don't have access to this technology, we've come up with a lot of other solutions other than a retrograde knuckle to help with ambiguity. So I would say I think this is a technology in its infancy, but is critically important for us to get better as a broader group to lead to safer and successful procedures.
So Farouk, 20% of all of our angiographies that end up having a CTO. Is this another cap, feather in the cap for CT? Anatomy first. Does this has this changed your practice from using nuclear studies more towards going on CT basis, knowing anatomy, knowing that we can also potentially measure physiology off of CT scanning? Has it changed things for you?
That's a great question. I am still digesting many aspects of the ischemia trial, which of course you were intimately involved in. I think there's still much to be learned. I think our post-CABG patients are really underrepresented in these types of trials and the complexity of what they have. So symptoms first dictate the need for CTO PCI. We do try to maximize medical therapy on 3 or 4 antiangiogenics before bringing people in if they do not have excessively high risk anatomy. But for single vessels, for example, we will look at symptoms. Once we know there's a total occlusion, um, if we really have concerns of ischemia making the difference, if we have a negative spec study, we have gone to PET for those patients to document ischemia, and that's been incredibly helpful. They're always accurate and always ischemic in normal EF patients. So CT has confirmed, I think, the critical importance of understanding anatomy to guide management, but for CTO PCI, it's still symptom driven.
So Farouk, I'm sold. I want to start doing it tomorrow. What are some of the practicalities? Do I have to use a Siemens system? Do I have to use a Siemens CT? How do I get the overlay? Talk to me about some of the practical steps that Ziad Ali wants to do a CTO on Monday using CT guidance.
Well, you're blessed at Columbia. You're ready to roll. And so because you have a Siemens-based system, which you do need as the X-ray system. Any CT can be used from the outside, any CT. Then extracting it is just from a single workstation that is a Siemens-based workstation, and then can go into your Siemens-based fusion system. But because we do so much fusion in TAVR and increasingly MitraClip, like this concept of fusion technology, hugely available for structural using similar tools. And Siemens have structural fusion technologies. This is just the next step for coronaries. And we expect other systems will also start to adapt it. But for you, you would be able to, I think, setting up some kind of reasonable understanding with radiology to help you get better at CT. When you start to have the interdisciplinary discussions, then it becomes much easier to use that technology over and over and then extract the information and bring it in. It really becomes quite seamless. Like we really do enjoy not having to inject contrast every time we think we're in a main vessel or a branch vessel. You just know from CT where it is a lot of times. And there's lots of things. It's just like having a roadmap. If that roadmap were there for you in every case, you would want it. It's just getting it takes a little bit of time and infrastructure, as you're essentially stating.
Well, Farouk, I think we both think that the future is now, because I just talked to you about angiography derived FFR, and you told me about overlaying someone's CT onto their chronic total occlusions. But I think Bill's going to win again here because this guy wants to do PCI using a robot. So, Bill, convince me that, first of all, I want to stay alive. I don't want to be a droid. I'd like to keep my job. I like doing PCI. I know you're bored. You've done everything a million times. But convince me and Farouk that the robot is going to help and move us forward.
I want to thank everybody for sticking it out and listening to this last talk. Hopefully, I'll be able to help Dr. Ali understand why I believe in procedural automation as a means to improve our quality of life and improve overall patient care. So these are my disclosures. So why use robots? Well, one of the problems we have is we're basically very well-paid coal miners, that we have a huge amount of occupational risks in the cath lab that are effectively ignored by everyone. So there's an 85% increased risk of brain tumors, especially in the left side. There's a 50% increase of cataracts. There's early vascular atherosclerosis of the carotids. And 60% of practicing interventionalists will have orthopedic issues at 20 years. And remember, in the general population, that rate is 2%. So standing in lead and working in a cath lab is incredibly hazardous and is going to potentially ruin your career or your life as you move forward because of all these orthopedic issues. So we really need to evolve how we do things to try and protect ourselves. The flip side to this, we'd like to also help improve the quality of care. So again, as we talked about, radiation exposure is doubled, orthopedic strains, and especially if you're trying to do left radial or even right radial. I mean, that is the thing people don't talk about is radial does have a higher exposure risk than femoral for a variety of different reasons. So these are ways to reduce your risks, okay? So again, if you think about it, interventional physicians receive more radiation dose than nuclear power plant workers, okay? That's a big deal, and it really does affect your cancer risk. And nobody really cares. I'm sure your hospitals don't really care that that's going to happen to you. So we looked at this interestingly in CTOs, because obviously the robot is not ready to wire the CTOs following Farouk's CT. Hopefully someday that will be what happens. But even right now, when we do robotic assisted CTOs, what we do is we cross the CTO. We then either go into the robot on an externalized wire, or we go onto it on an antegrade wire. And what we demonstrated over here is about 40% of our 40 minutes of our procedure time is actually in the cockpit. So I've reduced my time in lead by about 40%. Okay. Now, if you think about that on 100 CTOs a year, or in my case, 300 CTOs a year, that's a huge amount of time standing at the bedside. And if you were doing this for non-CTO PCIs, this is about a 95% reduction in the time that you're going to be spending at the table in lead. Now, my father, and that's a picture of my father on the left, was an airline pilot. And one of the reasons I'm involved with robots is I think in a large part, humans and the way we train is part of the issue. So mistakes are usually a accumulation of minor errors. High performance technology and preparedness prevents adverse events, but you've got to minimize the human error factor. Okay. There's some other things that we can talk about for complication management, but let's focus on the fact that most high performance aircrafts fly themselves. The pilot's job is actually not to fly the plane. The pilot's job is to manage potential disasters or emergencies that may arise. So training for commercial pilots and aviation and military pilots is not how do you fly the airplane. It's how to manage complications and potential disasters. So think about that and how you were trained to do PCI. You were basically trained how to put a guide in, how to put a wire, how to manage getting a balloon, how to get a stent, how to use a guide. You didn't actually learn anything about how to manage a coronary dissection, how to manage a coronary perf, how to manage a retroperitoneal bleed. We don't practice complication management. So what if we could make it easier for the procedure to be done so we could focus training actually on managing disaster rather than just doing the job? Okay. The other piece is, I get thrown out all the time. Oh, you're so amazing. You could just, all right, what if I can teach a machine to spin the wire the way I do? What if I can teach a machine to understand the algorithms that I'm using during a procedure to solve challenges within the case? That may not make me a whole lot better. Hopefully it will, but it will raise the bar of everyone else. And robots and automation and AI is actually about improving the minimum competency and setting a higher standard across a wider swath of people. And that's where I think this has potential real benefits. So right now, there are some what are called tech IQ or smart procedural automation. And what basically was done is several high-end operators went in and were tested in basically how much rotational speed they could generate, how much rotational uh, force they could generate, and also watching how much the angles of what they were doing, either with spinning, with doddering, and effectively they then took those series of very high skilled operators and built computer automation that allows the robot to act like those people's high-end movement. So it's sort of like going out with a robot and watching Brooks Koepka's swing and then having the robot mimic it. And that's going to make everybody be able to play at a higher level. So the first one was this one called rotate on retract. Just simply, you go past the lesion, you pull back, the wire automatically rotates and you go forward. And you basically just move the joystick back and forward and the wire will eventually find its way home. And what we showed is we could reduce wiring time 50% by using automated wiring. Who doesn't want to do their cases quicker? Okay. So then we decided we all do these other technical skills. So one of them is the spin. People tend to spin a wire down a coronary. So let's teach the robot to spin a wire down the coronary. The other thing people tend to do is wiggle a wire. So we wiggle it back and forth in about a 30-degree arc to help it find its way down. So let's teach the robot to do that. And this is the robot performing a human technique. How about daughter? Everybody's used the little jackhammer move. So this is the same thing with a balloon or stent. You're just teaching it to do an automated function. So that allows you to do more and more things, not at the bedside, but sitting back in the control room, drinking a cup of coffee, watching what's going on in a very controlled environment. to help you do your job. And you're not wearing lead and you're not getting radiated. And the last one is a constant speed. So if we want to perform IVUS or we want to perform other things, I actually tend to use the laser on the robot. And the reason being is I can make the laser go 1 millimeter a second. That reduces no reflow and provides better atherectomy. So this is sort of how it looks. You have the panel on the left is the catheter movement, in the middle is the wire, and on the right is the guide. So you can do everything with these control sticks that you can do at a table. And when I go onto the robot, my going back to the case live is less than 3%. And usually it's either because of a complication or actually a technical malfunction of the system, not that it can't do the things that I do. Now, this is just, again, the first iteration of teaching the robot to do things to help improve and make it safer. And this is just a little video of basically, this is a spin on the left, and this would be spin wiggle or spin wiggle on the right. And you can see how much quicker it's going. And again, that's just what we do during procedures. Same thing on the bottom is looking at the two animations and how it works. And I'll put out there for you, how amazing would it be in the future if we've done a CT scan, we know the patient's anatomy, we've done our virtual angiographic FFR, IFR, whatever R we're doing. I then just put a click and I point and click, the wire drives down the coronary, the computer tells me, oh, this is a 3.5 millimeter diameter vessel, so you need to pick this size stent. Or, hey, there's this much calcium on the CT scan, you must do atherectomy, you must do shockwave for vessel prep to optimize your stent outcome. And all of that can be done automated. And what I'm going to teach you to do is, how do you manage if something doesn't go quite right, or if the machine can't do it? And that will fundamentally raise the bar of everyone, because it will force us to have what is a true standard of care, which is where everyone's operating at a same high level, rather than what the current standard of care is, which is whatever is done within your own hospital. And that would be the end of my discussion. I did put a conclusion slide, but what I want to leave out for the audience is just that. Don't be afraid of this new technology. It's only going to help your patients get better care. It's only going to help you do a better job. It's only going to help improve your quality of life, both in the near and short term. You know, if you still have a phone that's plugged into the wall and you've got a cord, I don't think so. You probably all have an iPhone or a Samsung. You can't be afraid of this technology. You have to embrace the technology and use it as a way to help improve our profession in essentially no way that's really changed in 40 years. Ziad, we'll see if that changes your mind, but hopefully you're on board. You're a young guy. I'd like to be able to see you keep standing up straight when you're my age.
I don't know about you, Farouk, but I kind of stopped listening when he said that he could teach the robot to spin the wire like him, and I just ordered 2. So
you ordered 2 bills or 2 robots?
2 robots and 2 bills. So I kind of stopped listening. So I hope you have some questions for him.
I want to know if the bill can come with the robot. You know, that'll be the ultimate package.
Well, actually, you know, it's funny you bring that up, because one of the benefits is, you know, they've already done some PCI now where the operator was 32 kilometers from the patient. Yeah. Okay. But I would also put out is, you could see a world where you have a robot, you're on the robot, or you're in a case, and I have a robot, and you could just say, hey, Bill, can you look at my case? I can pull it up from my robot and, again, troubleshoot or work things out. And I think it's not necessarily that I'm going to take over the controls, but just the ability to potentially share in real time and help each other improve and sort of have these discussions, I think is another potential huge benefit of this technology.
Think about your true reach now that you might have, Bill. Like if you were to actually be able to control my robot and say, hey, you know, Farouk, I don't even want you to try this. You're just going to watch me I'm going to work on your robot and actually wire this area and do something that I think you just need to see me do. I'm in my office in Washington, and now I can do it for you. Like this is the whole telework that Siemens is really leading in stroke. What about doing this to advance our next generation of training and proctoring and things like that, live cases. Is that possible?
I think, it's basically, it's a bandwidth issue and a HIPAA issue. And a medical legal issue. Actually, I have a meeting with my institution on Monday to discuss site of practice, which I need to cover the medical legal of virtual proctoring. And I do think this has a potential to have huge changes on how we train people, and partly as fellowship, but even more importantly in the postgraduate setting, so that how do we keep our whole profession continuing to improve? I think the other is as you get machine learning, I think it's called deep learning, and AI working collaboratively, again, it's not necessarily that I have to take over the robot, it's that the robot has my 4,000 CTOs in its memory. And so it can analyze the case. And, the joke is always, I remember one case from 3 years ago where I did this one thing to solve this one problem, and I'm good at pulling that back out at the time I need it. Well, now the robot can do it because we can teach it to do it. So I look at this as like an Apple IIc, that this thing is just, they basically made a board. It's got a little floppy disk and it's 64K. But if you can think about what an iPad looks like from there, I do think that's where this technology has the ability to go to. I think the bigger hurdle will actually be the operators and how it affects their ego, as Z said. Am I going to lose my job? And I think we need to change the focus of training. And again, more like pilots, is we focus more not on how to put a stent in. What we focus more is how to manage the complication of putting a stent in so that people are excellent at managing those things. And that will reduce fear, especially in these high-risk procedures that we're talking about, like unprotected left main, atherectomy cases with lots of calcium, CTOs, low EF, all of these different things. We then have a better network and safety of training to allow people to tackle these harder cases.
It's interesting. Sometimes I wonder if if we learned this first, right? Imagine we learned on robots and then somebody said, hey, go do it by your hands. You'd be like, are you crazy? I'm not doing that. And, I have to say your slides at the beginning, Bill, were extremely impactful, right? I mean, I'm a young guy. I exercise every day, but I have back pain. I can't lift up my daughter for more than 4 or 5 minutes before I start to get sciatic again. And I do everything I'm supposed to do. Not to mention the amount of radiation that we're getting and the cataracts. And one thing I couldn't agree with more, Bill, when it comes to stuff like that, if you don't care about yourself, nobody else cares.
Again, I always like the coal miner reference, right? We have a lot of people out there hurting themselves at the cause of taking care of patients, which I get, but your institutions aren't taking care of you. And I'm frightened by this too. And that's why I think the younger operators, one, I think you're more savvy with technology, but two is my back damage is done. I'm just trying to minimize it getting worse. You guys can potentially avoid it. And anything you can do to not wear lead is going to be hugely impactful.
Well, Farouk, Bill, this was a lot of fun. It felt totally natural. It was just like talking with a bunch of my buddies about modern day interventional cardiology. And I think somewhere in the talk, I talked about the cath lab of the future, but the reality is the future really is now. We talked about FFR guided by angiography. We talked about CTOs guided by CT scanning and by robots doing PCI. So I want to thank Siemens for sponsoring this session, and I hope that you all enjoy the rest of TCT Connect 2020.